In Cirrhosis 1, we talked about the etiologies of cirrhosis, that is, how you can become a cirrhotic. It was the same as the videos you'll find in the 3rd and 4th year clerkship videos. Now, I want to talk about decompensation. What happens when someone has cirrhosis and gets worse? The first thing I want to point out is that there is no such thing as an acute exacerbation of cirrhosis. They can get worse from where they were, but decompensation implies going from someone who does not have varices, ascites, or encephalopathy to someone who does. So let's see the spectrum of what a cirrhotic could be like. You may have the diagnosis of cirrhosis. It is diagnosed by biopsy or some sort of liver tests. But that cirrhosis is a big spectrum. You could be grade 1 with very little disease to grade 4 with very much disease. But as long as you do not have those things I just mentioned, you are compensated. You can, of course, have no cirrhosis, become a cirrhotic, and then decompensate. And once you decompensate, you are very close to death or transplant. And the reason why I do it this way is because you can go from no cirrhosis directly to death or transplant if you have a fulminant hepatitis. This is the consideration of disorders where your AST and ALTs get into the thousands. The Tylenol, viral disease, autoimmune hepatitis, vascular event like a cloud or Budd-Chiari, or shock liver. That can take a non-cirrhotic to the need of transplant or will kill them if they're fulminant hepatitis. But a long chronic process develops a non-cirrhotic into a cirrhotic. And a compensated cirrhotic, one who does not have hepatic encephalopathy, varices, or ascites, has a lifespan expected to be the same as a normal individual. If they decompensate, this generally happens in about 2 years. It doesn't have to, though, because now we have medications to control them. So let's just review briefly the major cause of problems in a cirrhotic, and that is ascites. So if you have cirrhosis, 3 big major pathophysiologic changes occur. One of them is that you lose albumin. So you have a decreased oncotic pressure. The other is that you have portal hypertension. The portal pressures go up. The way this happens is that most of your blood supply, about 30% of your cardiac output, goes to your gut. All of that blood flow has to come back out through the portal vein, through the liver, and into the hepatic vein. The problem is that as your liver gets scarred, you lose those hepatic veins, and so the portal pressures build up as the portal vein fluid has nowhere to go. As the portal vein fills, the portal pressures increase. Hydrostatic pressures push fluid out, and that leads to ascites. This condition is exacerbated by the fact that there's also a low oncotic pressure. Because of the low albumin, that fluid leaks out of the vessels easier, leading to ascites. But one of the major pathophysiologic consequences of cirrhosis is peripheral vasodilation. For whatever reason, we cannot get good supply of blood to the periphery, and so there is vasodilation. Vasodilation of the splanchnic vasculature increases portal flow, worsening portal pressures. But something else happens, and that is the activation of the renin-angiotensin-aldosterone axis. And so we go back to our familiar chart of the nephron. With its Katrina switch. Katrina switch because it's backwards. Down is on, up is off. It makes renin, which turns on Ang2, which turns on aldosterone. Now you may be frustrated by this because if you've watched heart failure already, you know that a low flow state to the kidney is going to upregulate Ang2, which increases systemic vascular resistance. Well, the liver turns out is more powerful than the heart, and despite elevated Ang2, SVR is still down in a cirrhotic. The major pathophysiologic consequence to the renin-angiotensin-aldosterone axis in cirrhosis is the effects of aldosterone. Aldosterone is designed to reabsorb sodium through the ENaC channels and loses K. It also happens to work on hydrogen ion excretion and reabsorption of bicarbonate. But it absorbs the sodium so that aquaporin channels can do their job and reabsorb water, because water follows salt. In a cirrhotic, there's not a lot of forward flow because all of the intravascular volume ends up in their belly. The body senses a low flow state. Little perfusion of the kidney, low GFR, low flow through the system, gravity pulls the switch to on, so renin, Ang2, and aldosterone go up. Aldosterone pulls in more salt from the tubules so that ADH can pull in more water through aquaporins. The person becomes volume up, more sodium and more water reabsorption to try to replete the vascular volume. But the splanchnic vessels are dilated, and so all of that extra volume goes into the portal system and ends up in their belly as ascites. So the pathophysiologic consequence of being a cirrhotic with low flow to the kidneys is not an increased systemic vascular resistance. The liver wins in this case. What matters is that also aldosterone is upregulated, reabsorbing sodium and water. And so attempts to intravascularly replete these patients is going to end up with all of that volume in their portal system. And with that activation of the renin-angiotensin-aldosterone axis, you get worsening ascites. So ascites is a major component of liver disease and is a product of portal hypertension, low albumin, and the renin-angiotensin-aldosterone axis. We can intervene to help ascites based on these things. For example, we can give a low salt diet with fluid restriction to limit the impact of the renin-angiotensin-aldosterone axis. Since sodium reabsorption is the primary error and aldosterone activity exacerbating the condition, we can give diuretics. In fact, you start Lasix and aldactone. You start low and work your way up, and you keep increasing the Lasix and aldactone doses until the creatinine bumps. The idea being that you're going to push the limits of these medications in order to get as much fluid off as you can. To attack a low albumin is very challenging because if you give albumin infusions, all that's going to happen is the albumin wears off. But albumin can be used in an acute setting to replete the intravascular volume. And generally, albumin is not used on a chronic basis. Portal pressures can be worked around with a TIPS procedure. The risk of TIPS is that it bypasses the detoxifying effects of the liver and can lead to worsening hepatic encephalopathy. A TIPS procedure is essentially a tube placed from the portal vein to the hepatic vein, bypassing the liver, bypassing the increased pressure, allowing flow to remove the ascites. This is usually reserved for when those increased portal pressures are causing more than ascites, like life-threatening esophageal varices. We'll get to that in just a second. And of course, the main etiology of all of this is a bad liver. So if we do transplant, we can reverse all of this and the ascites will resolve. The reason why I start with ascites is because ascites is the most important thing that's going to affect a patient long term. So there's two things that can occur as a product of ascites. Once you've got it, you can develop what's called spontaneous bacterial peritonitis, which is why every patient who presents to a clinic with new onset ascites or presents for admission to the hospital for acute decompensation, no such thing as acute exacerbation, but there is a worsening, acute decompensation, gets a paracentesis, a diagnostic paracentesis. The presentation of SBP is anything, including nothing. They may be infected and not be able to tell you. So if they have any acute change, that is one that would bring them into the hospital, or they have new ascites, you want to make sure it's not SBP. You do that with a paracentesis, and what you are looking for is very specific. You are looking for greater than equal to 250 polys. Not white cells, specifically polys, neutrophils. If that, then you have SBP and you treat with IV ceftriaxone. If you see nothing, congratulations, you do not have SBP. But there's one part of this you have to consider. You send that diagnostic paracentesis for cultures because you presume if it's greater than 250 polys, it's spontaneous, treat with IV ceftriaxone. But if that culture comes back with 2 or more organisms, that is not spontaneous, that is secondary bacterial peritonitis, and that means they have a perforation and they need to go to X-Lab. Brief overview, obviously more details are required for spontaneous bacterial peritonitis, but what you want to take away is if new onset ascites are an acute change in their condition, tap them, send for culture. If greater than 250 polys, IV ceftriaxone, reassess in 2 days. If no 250 or more polys, then not SBP, don't worry about it. And if it comes back eventually as 2 or more organisms, keep the antibiotics going, but recognize you've got a perforation somewhere. But a paracentesis can be used for more than just the diagnosis of a spontaneous bacterial peritonitis. A paracentesis is required for the diagnosis of the ascites. Remember the equation from fluid where fluid shouldn't be, the simplified version of J equals K times hydrostatic minus oncotic. This is the one instance where the oncotic pressure of the interstitium actually matters. When you take a paracentesis, what you're going to get is a SAG, a serum ascites albumin gradient. Serum ascites albumin gradient. You take this serum albumin, you subtract from it the acidic albumin, and that is your gradient. If you have a SAG score greater than equal to 1.1, that is, there is a lot of protein in the blood, but not a lot of protein in the ascites, it means it is portal hypertension related, most likely to be from cirrhosis. If, however, the SAG is less than 1.1, it means that there's a lot of stuff, a lot of protein in the ascites, which means that something else is drawing the fluid in there. The oncotic pressure in the ascites is elevated, which either means infection or cancer. Now, of course, the differential for the SAG score is much higher, but as you tune in, what you're looking for is, I think it's portal hypertension related, greater than or equal to 1. If it's not portal hypertension related, it's probably less than 1.1. There's some more studies you can do, but as you tap every person, you're also going to get an albumin to make sure the diagnosis is confirmed. They have ascites because they have cirrhosis. They don't have ascites because they have ovarian cancer or tuberculosis. Okay, so we're talking about ascites in particular, and right now we have the treatment for ascites, including salt restriction, water restriction, diuretics, a TIPS procedure, and transplant. If you've ruled out SBP, you can also do large volume paracentesis. Where you actually put a needle into their belly and drain off as much fluid as you can. That's temporizing, it is going to reaccumulate, but it will cause symptomatic relief for these patients. When you do a large volume paracentesis, you have to remember to replace the albumin. Generally, you give 25 grams of IV albumin, that is 25% times 100 cc's, following a large volume paracentesis. That's usually enough to cover. You give them oncotic pressure so that they don't immediately redistribute all their intravascular volume directly back into the ascites, causing hypotension. Okay, we've talked about ascites and SBP. Let's talk about some of the other complications of a cirrhotic. One being esophageal varices. When you have an increased portal pressure, the portal pressures get so high that you're going to create portosystemic shunts, portocaval shunts, from the portal vein to the vena cava, portocaval shunts. These are shunts that existed in the fetus state but have since closed, but they can reopen if the pressures get really high. The ones that the patient cares about are going to be the hemorrhoids and the varices. The ones that we care about are the varices and maybe the caput medusa that we can see. The one that we both care about is esophageal varices. Why? Because they bleed and they kill people. The portal pressures get so high that the esophageal varices get engorged. The veins of the esophagus just protrude out, and any type of contact from food or simply too much volume can cause them to rip and bleed. Esophageal varices bleed, and they bleed a lot. And an upper GI bleed secondary to esophageal varices has a very high mortality associated with it. The earlier you do the endoscopy, the better. To temporize the patient, to prevent them from dying before GD can be done, you can place a Blakemore tube, which is a temporizing tamponade of the vessel, but the EGD allows you to get in there and do banding or scleral therapy. Clip it. In addition, before the EGD is done, you can give octreotide. We talked about this in the GI bleed lecture. Octreotide drips decrease the portal pressures, and hopefully that the big pressures that rip that vessels will decrease. Studies have come out in 2013 that have told us that we do not want to transfuse. You transfuse, of course, if they're symptomatic. You transfuse if they're less than 7, but you do not want to overtransfuse these patients because all you do is fill up the portal system, preventing a clot from forming. The EGD is the mainstay of therapy and needs to be done within the first 24 hours, generally within 6 if the person's going to live. Once they're over the acute event, they get started on beta blockers, either propranolol or nadolol. Both of these are beta blockers that make the patient feel like crap. But what it does is it decreases the portal pressures, so it decreases the risk of variceal bleeding in the future. What you want to do is start them off at low dose. Wait 3 months, allow them to equilibrate to the sensation of feeling crappy and their receptors sort of recalibrate, increase the dose. And you continue to increase the dose until they cannot tolerate it any further, because the higher the dose, the less likely esophageal varix is to rupture. And anyone who is a cirrhotic needs a screening endoscopy. So the EGDs are both therapeutic and the means of diagnosis. Because if the person hasn't had a bleed but is a cirrhotic and they have a varices, they're considered decompensated and you want to treat them anyway. The last thing that defines you as a decompensated cirrhotic is hepatic encephalopathy. This is a product of pneumonia getting to your brain. The liver normally processes the ammonia. The problem is that the ammonia in your blood poorly correlates with the ammonium trapped in your head. The ammonium in your brain causes fluid shifts, and fluid shifts are bad, and it causes confusion. When you see someone who has cirrhosis, it's difficult to tell if they have hepatic encephalopathy or not, because it's graded on a scale of 1 to 4. Your goal is to get them to be without any encephalopathy. But the grade is based on how severe they are. Grade 4 is the worst. It's a coma. And of course, you're not able to assess for the hand flapping tremor of asterixis. Stage 3 and 4 are going to be in the intensive care unit with great assuredness. 1 is not free of symptoms. 1 is someone who is a little confused. This is someone who forgets their keys or has trouble paying bills. There is no asterixis. And I'll show you that there's no asterixis at stage 1, and you're not able to assess asterixis at stage 4 because they're in a coma. This is why I talk about them first. But you know people who do this, who aren't cirrhotic. So how can you be sure that they don't have encephalopathy? Well, you know that because they don't ever decompensate and get worse. The difference between stage 2 and stage 3 is subtle. But let's give you a more concrete example. Stage 3 is going to be someone who is completely out of the box. They're thrashing around, making incomprehensible sounds. They're moaning and groaning. They're pulling at restraints. They need to be restrained. And if you get them to cooperate long enough, they will have asterixis, and it will be severe. Asterixis is actually the loss of tone. You have them, their hand fully extended and their wrist extended upwards. And you ask them to hold that position. The ammonium in the brain causes a loss of tone, so they lose tone. But they're trying to hold contraction. So what it looks like is a flapping tremor as they lose tone and regain it, lose tone and regain it, lose tone and regain it. You don't have to do this with hands. You can have any sustained muscle contraction. They will lose tone briefly and then regain it. That's a sign of asterixis. So the stage 3 person is completely out of the box, thrashing around, becoming nonsensical, moaning, groaning, and not really being able to communicate. Whereas grade 2 encephalopathy is more inside the box, but still out of it. This is the person who's a little more confused, may not know where they are, can respond to you and answer seemingly appropriate questions, but aren't behaving quite right. They're not crazy, they're not thrashing about, but they're worse off than just forgetting their keys, and they will have asterixis. To treat hepatic encephalopathy, you give them lactulose, rifaximin, and plus minus zinc. The goal is to eliminate the ammonium in the gut. The lactulose changes the pH of the gut and induces diarrhea. You want to titrate to 3 or 4 bowel movements per day. The more bowel movements they have, the less ammonium can be absorbed from the gut. Rifaximin is an antibiotic that destroys the gut flora that produces an environment less conducive to producing and absorbing ammonium. And zinc helps with bowel movements. And so to summarize this lecture, what I want to go back over is just the generalized treatment for someone who is a decompensated cirrhotic. To prevent hepatic encephalopathy, you'll be on lactulose and rifaximin. As you try to deal with esophageal varices, if they have it, you'll start them on either propranolol or nadolol. These are all chronic medications now. And if they have ascites, you are going to sodium restrict, volume restrict, and give them diuretics. From time to time, you might perform a large volume paracentesis to reduce symptoms. And you can at least consider giving a TIPS procedure, knowing that bypassing the liver can worsen hepatic encephalopathy, and transplant is ultimately the answer. But in the acute setting, where someone comes in who worsens, and this is the most important thing for you to learn from this lecture, because what you are going to see as an internist is the acute decompensation. If ever you find someone who has gotten worse, and by worse, I mean they show obvious signs of sepsis, or they're MELD bumps. We'll talk more about the MELD score in the next lecture. Or they have hepatic encephalopathy. If they show any signs of deterioration, what I want you to think of is fluid, infection, or bleed. The treatment is going to be essentially all of the long-term therapies, except you hold the beta blocker and give them octreotide. And to prevent them from becoming volume down, you give some albumin. So I want you to pay attention to the chronic therapy, but I want you to also recognize that when someone comes in, it's fluid, infection, or bleed that's causing their acute decompensation. We'll talk a little bit more about some of the other consequences of cirrhosis in the next lecture and attack fluid infection and bleed more aggressively.